Welcome everybody to Grand Rounds. It's my pleasure to introduce our speaker today, Dr. Lori Lalakea, well known to many of you and really a pillar of our training program here at Stanford. And Dr. Lalakea trained here and has spent her entire career here, currently clinical professor of otolaryngology and chief of the otolaryngology head and neck service at Valley Medical Center. Also renowned for her teaching capabilities and mentoring capabilities, and winner of the teaching award 4 times, I believe, right?
Yeah.
And many more, I'm sure, to come. So we're really thankful, Lori, for your time today to learn from you, from your experiences and your wisdom about mentoring and feedback. So we're going to start with just a few questions, and I'm just going to have a seat and let you take the podium. Since you've been here for your entire career and you trained here, can you just tell us a little bit about what it was like for you pursuing feedback as a resident here, and what the system was like back then, and how has that evolved over time, and how has your ways of delivering feedback changed over time?
Well, first, thank you for the kind remarks. I really appreciate it. I would say that when I was a resident, there was not such a focus on feedback. It was more of an expectation that you would be performing well. When I was a resident, there was a lot of focus on our in-service scores, for example, which wasn't all that helpful. And we get some written feedback evals that were more of the good job or needs more work variety, but not the kind of feedback that we are more familiar with now. And so I would say it's been an evolution over time. It's certainly gotten more touchy-feely, if you will, more learner-focused as compared to performance-focused, like do your job and take care of patients and keep your nose clean. It's definitely been an evolution for me to speak up more. It is not my natural style to speak up more. So it's something that I definitely had to work on.
And maybe just in your journey as a teacher, how did you decide that dedicating time to feedback was important or necessary? What were the things that came up where you realized that you needed to incorporate this into your teaching armamentarium?
I mean, I think it was in part a change in mentality over time through the teaching program. I think probably it was a resident or two who said, "Hey, can we have some feedback?" And I would think, "Oh, what am I going to say?" And then having to take a very deliberate approach to think through, how can I do this? How can I sit down and talk with somebody for 10 minutes or 20 minutes about their strengths and their challenges? So I will acknowledge that I'm horrible at impromptu feedback. If you accost me in the hallway and say, "Can I have some feedback?" I just, nope. We can set a time for it, absolutely, the next couple of days. So for me, very, very deliberate and stepwise. One thing that I mentioned a little earlier is that it's been such a pleasure and reward, really, to help those who need a little more formative help and nudge here and there, and seeing how they come out in the end. That is a huge reward to me as a teacher and has helped me to stick with it.
Wonderful. Well, we really look forward to your presentation, so please go ahead.
All right. Well, hello, everyone. Good evening and welcome. Today's topic is feedback, why improving is worth the work. Tina Stankovic proposed this topic to me a while back, having heard, I believe, that I have on occasion provided feedback that others have found to be helpful. And she asked me to share my perspectives. Let me just give a disclaimer. By way of background, I have no special training in feedback other than the occasional talk or training session that most of us have attended. I am personally introverted and conflict avoidant, so not a good setup. My natural style would be more along the lines of silent disappointment, which is a style that we'll cover a little more later. Despite having served and attending for years, I still find giving feedback to be challenging. And to the extent that I have any facility with it, it is something that I've worked to get better at. I hope to be able to convince all of you that feedback is important, that one's skills can be improved, and to provide you with some tips on how to surmount the barriers that prevent you from engaging more willingly in the feedback process. While this talk is slanted more towards providing formative feedback to residents, I want to acknowledge that positive feedback is equally important, as is the process of residents providing feedbacks to attendings. For residents who ultimately do not end up in teaching roles, I would note still that feedback skills are super important, that you will need them in the clinic and in the OR and in your leadership roles to come. We can all do better. I have no disclosures. Okay, we should acknowledge up front that feedback in medical education, as in any context, can be hard. Ideally, it is an opportunity for the giver to teach and mentor and for the receiver to improve competencies. But it can take an emotional toll. Formative feedback is especially fraught and may provoke defensiveness. And of course, when that occurs, feedback leads to disappointment or a sense of betrayal and may be dismissed as invalid. Feedback has the potential to go sideways. Such exchanges may pose a risk to the relationship. We may worry about retaliation, and feedback that goes sideways does not achieve its goal. While it can be difficult, there are many reasons to learn to be more comfortable with giving feedback. Of course, we know that when done well, feedback can enhance learning and development. It has the potential to advance individual as well as team performance. And perhaps most importantly, we advance the critical goal of patient safety and care excellence, now and future. For me, that was one of the reasons that changed my view towards feedback and increased my motivation to engage in feedback. Because of course, we are all committed to care excellence and team competence. Residents at all levels are integral members of our team. So as educators and leaders and team members, we need to embrace our commitment to continuous improvement. Feedback aimed at developing individual and group skills and moving basic competence to exceptional competence is central to that process. And of course, we also give feedback because trainees want feedback. We hear this from our own residents, and there's abundant literature supporting the strong desire of trainees across disciplines for feedback. Moreover, this literature demonstrates that feedback given in training programs often comes up short or is perceived to come up short. Another reason to commit to feedback is really saying nothing is worse. The absence of feedback is in itself a kind of feedback. The learner may wrongly assume that the performance is adequate, which may stall or plateau performance. Lack of feedback can also lead to uncertainty and anxiety. The learner may be aware that they are falling short, but not the how and the why. The trainer, on the other hand, may feel disappointed or frustrated or resentful, and that often comes across in body language or aloofness. The trainer may end up taking on more work. The learner misses the opportunity to improve. It is a lose-lose. A final reason for giving feedback, of course, is we're supposed to. We sat through lectures, and now you're listening to another one. We've been asked to do more and do better. We get regular reminders on MedHub. We know we should, and yet we still have a way to go. We can do better. I spoke with Erica recently while preparing for this talk to get a sense of how we're doing. There are currently 400 pending faculty evaluations of residents from July 1 to present, just here in otolaryngology. Even if most of those are eventually turned in, we can at least say not timely. Our track record with respect to feedback is also reflected in our program ACGME surveys. For the last academic year, 76% of our residents were satisfied with feedback received, which doesn't sound horrible, but the national average is 88%, so we fall well below. Also, faculty satisfaction with feedback received regarding their teaching skills is even worse at 63% versus 89% for the national average. Okay, so how do we get to better? For the remainder of the talk, we'll be covering the following topics. We'll start first with a definition of feedback in the context of medical education, including some newer definitions for a more collaborative approach. We'll spend some time talking about barriers to feedback and how we might address those. We'll cover some basics regarding best practice building blocks for delivering effective feedback. We'll briefly touch on some characteristics, on some feedback methods as a framework for developing your own style. We'll include a quick how I do it section under that topic, and we'll conclude with a few pointers that I have found to be especially helpful. Okay, what is it? Here's a standard definition. Feedback is specific information about a learner's observed performance as compared to desired or standard performance with the intent to improve the learner's performance. This may be from a trainer, for example, an attending or a senior resident, to a learner, such as a resident or student. It may be from resident to attending, or it could be peer-to-peer or 360. Traditional feedback has its limitations. It's largely a one-way communication. And I would note that for those of you who prefer written feedback is really always one way. The trainer gives information to the learner accepts that information, the learner acts to improve performance. But there are multiple ways for this to fail. The trainer may fail to give feedback. Think of all those pending MedHub evaluations. The trainer may give poor quality info, like good job. The learner may not accept the info due to defensiveness or anger. And even if the learner accepts the information, the learner may lack the tools or support to improve. In this context, I think it's important to understand that feedback is subjective in nature, and therefore a one-way process can be a setup to fail. It is not sterile data. It is not an exam score, but rather is an analysis of performance with a very human perspective, given and received through a personal lens, and as such, prone to assumptions and biases. Newer approaches to feedback encourage two-way exchange, such as the reflective conversation, with the goal of greater agreement and efficacy. Okay, one of these collaborative approaches has been termed an educational alliance, proposed by Tilio et al. It's akin to the therapeutic alliance in counseling and psychotherapy. So it moves beyond the idea that effective feedback delivery by a trainer and acceptance by the learner is the goal. Instead, feedback can be improved by considering it to be, quote, a negotiation in the environment of a supportive educational relationship. I actually find this concept to be quite a powerful one. Because with this, educators can be considered as an ally or a partner, and that the resident is not standing alone. Feedback delivered in this context is intended to support the trainee's educational journey. Some of you may recall seeing this definition when Dr. DeGolia spoke with us a couple of years back. It's from Lefroy and colleagues in 2015, based on review of the medical education literature and expert opinion. Helpful feedback is a supportive conversation that clarifies the trainee's awareness of their developing competencies, enhances their self-efficacy for making progress, and challenges them to set objectives for improvement, and facilitates their development of strategies to enable that improvement to occur. So that's kind of a wow. If we were all world-class feedback masters, we would do this every time. But it's a lot to expect that level of mastery. We're all busy. The Lefroy definition may be beyond our day-to-day bandwidth. And I would say it is beyond mine. Okay, so that's a good segue into the next part about barriers to feedback, the many, many reasons why it can be hard to embrace making feedback a priority. So I've listed some here, and I think you've probably seen these. We're all busy, time is short. Insufficient exposure is a real issue with so many residents, so many attending, short rotations, because meaningful feedback is difficult without longitudinal exposure. Regarding don't know how, common concern, and we'll give you some tools later in the talk to help address this. So the next slides will focus really on items 4 through 6. Okay, relationship issues. We want to be liked. I mean, all of us do. We don't want to hurt somebody else's feelings. We worry that giving feedback will cause the receiver to like us less and strain our working relationship going forward. And is it worth it? But I really think it doesn't have to be that way. The relationship threat is mitigated by offering the feedback with goodwill and with the intent to be helpful rather than critical. This feedback is for you. It's given to you in support of your goals with the hope that it'll be helpful. And with that mindset, I actually feel like speaking up often clears the air and promotes a stronger working relationship moving forward. Next, fear of retaliation. The fear is real, but is retaliation a reality? It's related to relationship damage, but with the added concern for reprisal that could result in career consequence for the faculty or resident. Of course, this fear is the rationale that we pool feedback and we deliver it anonymously, that we delay the release of feedback back to the faculty. But even with these measures, residents and faculty alike still have concerns that when they give detailed and specific feedback, it will be traced back to the individual giver with negative personal consequence. So as retaliation is a major concern, I'm going to go through a couple of studies in the coming slides. This one was a 2016 paper from a general surgery program, and it looked at the relationship between scores given by faculty to residents and scores given by residents to faculty. And they found a significant relationship with a R score of 0.4. So faculty who rated residents more highly also tended to receive higher ratings from residents. The size of the effect was 0.28 points lower on a 10-point scale for every 1 unit lower that a faculty teacher provided on average. So these were pooled data. But you can see there's quite a lot of scatter. So there are some faculty who received low teaching scores who gave high resident scores and vice versa. The authors called this a reciprocity effect and postulated that rather than retaliatory, it may be more due to relational factors, such as do highly performing residents inspire us to offer more and better teaching? Do better teachers result in residents who perform more highly? Do residents with low motivation result in low motivation to teach? Or things along that line. So not clear that it's a retaliatory effect. This paper was a survey study by Wohl-Paul et al. 2 large anesthesia programs. So the survey was conducted from residents and faculty in their program regarding attitudes towards constructive feedback. Surveys included 4 specific fictional examples felt to represent best practice feedback. The study found that residents were very unlikely to lower a faculty evaluation in response to constructive feedback. Only 2% reported they would be somewhat likely to lower a faculty score, and none reported that they would be very likely. One other quick note was that in-person feedback was significantly less likely to be upsetting compared to written feedback with the exact same content. Okay, and finally, this is a quantitative study by Baker et al., large academic anesthesia program, that showed a near zero retaliation impact for confidential feedback provided to trainees. In this program, both faculty and residents evaluate each other weekly. Residents receive those evals every 2 weeks, aggregated, while faculty receive their evaluations every 6 months, also aggregated. They looked at macroscopic effects, so mean clinical resident performance score versus mean clinical teaching score, and found no effect. And as you can see on the lower slide, they broke it out additionally and looked at only just completed dyads. So the data was only included if there was a mutual feedback submitted to the resident and that same resident submitted feedback to the faculty. And with that, there was a very small retaliation effect, averaging 0.05 to 0.11 teaching point decline for every 1 point change in resident performance score. This was out of a 100-point scale. So on average, 0.1 point decline, pretty small. So I would say that overall, the literature supports the conclusion that fear of retaliation is larger than reality. When there is an established relationship between teaching scores and resident scores, the causative link is far from established. Just a quick word that intent and content are important. We should never do unkind or judgmental feedback, but supportive feedback given with developmental intent may be considered at low risk for reprisal. Okay, this was a big one for me, moving from reluctance to willing, how to address the motivation to engage more willingly in feedback. So here's 5 tips that really I found have helped me over the years to be more willing. The first is something that was shared with us by Joe Shapiro, who came for a grand rounds years back, and is called the benefit of the doubt. So it goes like this. Most people come to work every day wanting to do a good job. Wow, of course. So then, to the extent that there is a performance gap, we should not assume that it is intentional or fixed. People, especially Stanford residents, want to do a good job. So, of course, they would want to know if they are not meeting or exceeding a desired standard. Of course, they will want the opportunity to improve. Most likely, the learner is unaware of the gap or aware but unsure of the fix. So we owe the learner our insight and support, gladly given. The second tip is the learner's track record. They have been successful and can be successful. Residents have an incredible history of success with challenges met and surpassed. Past success implies desire and capacity for ongoing success. We owe them our belief in their potential and our commitment to their success by providing developmental feedback. Another frame that I have found helpful is I've nicknamed, it would be easier to let you pass through. Just let you rotate off without saying anything. So I am taking the harder path of offering you thoughtful feedback as a manifestation of my care for you. I see you and I owe you my honesty. Feedback is being given because I care about you and your progress. Frame 4 relates to the concept we discussed earlier of educational alliance. We can be aligned together with respect to 2 important goals. Of course, we are both committed to excellent patient care today, tomorrow, and when you graduate. We can both commit to the goal of your success, developing into an excellent physician and surgeon, and getting you to where you want to be. We can be allies, committed to that intent. And finally, my last tip for this is embrace feedback as essential to your mission as a leader and educator. Some of my most gratifying experiences as a teacher have been supporting those who needed a few extra doses of formative feedback and having played some small role in their victories. Take pride and satisfaction in the part you play in developing others. Pay it forward in appreciation for those who have mentored you. lean into your role, and be a force for good. All right, so I'd like to go through now some of the characteristics of effective feedback as guideposts to being a more confident feedback giver. Effective feedback, of course, is influenced by several factors. It should have quality intent. It should be delivered in a way that is heard and results in buy-in and an action plan. Giver and receiver characteristics play a role as well. Maintaining a behavioral focus is key to effective feedback content. Comments should be based on observed behavior at the performance or task level and not at the level of the person. There should be no character labels, such as this resident is unmotivated or disorganized. The person is not disorganized. Yes, their notes could benefit from better organization, or yes, their management of tasks on the inpatient ward could benefit from a more ordered approach. This focus on behavior reduces the chance of a defensive reaction. Equally important to avoid assumptions about intent, although it can be fair to discuss how a behavior could be perceived by others. For example, when you do X, it could be perceived by others as cutting corners. And I know you wouldn't want to be at risk for creating that impression. Feedback is also directly affected by the quality of the diagnostic assessment, which I call the gap where they are and where we want them to be. So what is the specifics of that gap? What are the specific things that a trainee is doing well? Comment about quantity. It's important not to be overwhelming in terms of the individual's capacity to hear and act upon the information given. And some sources suggest limiting it to 2 to 3 items at a time. Feedback should be actionable. So the behavioral focus implies that behavior can be changed and that solutions are possible. It should include insights and tools for performance improvement. A comment that operative skills are behind is not as helpful as the comment regarding 2 or 3 specific OR skills that could be improved, with suggestions on how that might be addressed. For learners who have already achieved some basic competence, feedback can be given in the form of a hint or a suggestion for their consideration. But for more junior learners, providing a more direct or prescriptive recommendation may be a better approach. Of course, the manner of feedback delivery is crucial to its success. It should be supportive and non-judgmental with a developmental focus. Collaborative problem solving and goal setting are considered best practice. The giver should take into account the learner's self-esteem, as feedback threatening to self-esteem is unlikely to be successful. Feedback should attend to learner motivation, the why and the you can. So the learner needs to understand why the change is desirable and why it is relevant, whether it be for patient safety or personal growth, better team, career success. It's not just because the giver says so. And for those of you who are parents, you're aware of that. It's not as compelling because I say so. It's more compelling if we understand and agree on the reason. The you can highlights that the change is attainable for the learner. When possible, verbal feedback is preferred over written because it can be more timely. It can allow for reading of body language and assessment of understanding, some give and take. It also has the advantage of being upfront and transparent, and I think that is really important. Of course, we want to be timely. However, when emotions are high, delay. In the moment feedback works best, I think, for less complex competencies, such as improving your notes or adjustments to your technical skills. But for more complex competencies, a more measured and thoughtful approach is needed for things like professionalism or decision-making. I find I need time to diagnose what is the exact gap here and how can I best frame it, and to consider what the solutions might be. All right. To be effective, the giver has to be trusted, or the feedback won't be trusted. And there are a few components of this. Of course, the giver has to have domain knowledge and competence so that they are credible. Second, the feedback is seen as most trustworthy when the giver has directly observed the learner's performance on multiple occasions. Third, the giver should not be seen as the other, but as a member of the same team, working together with mutual goals. And finally, but most importantly, the giver has to be trusted emotionally, as not out to get you, in the sense of psychological safety. The giver should be seen as someone who is honest, fair, and approachable, acting in good faith and with goodwill. Quick comment on receiver characteristics, as they also have a role in feedback outcome. Those with a learning goal orientation compared to a performance goal orientation are more likely to receive feedback as an opportunity rather than a disappointment. A growth mindset is ideal, that growth is possible, that change is incremental. But I think really the most important thing is the ability to receive feedback as a gift. And that's hard. It's hard for those of us who have a tendency to receive it as a disappointment. I think it's best to try to greet it as, this is important data to use. Hopefully it makes the receiver aware of and able to address performance gaps. But even if the receiver doesn't fully agree with the feedback given, it's still important information about how one is perceived by the giver or maybe by others. And that in itself warrants some self-reflection and possibly a course adjustment. But the bottom line is, no matter what our natural learning style and goal orientation are, we can all work to improve our ability to receive feedback with as much objectivity as possible and to reframe it as a gift. Maybe not the one we were really hoping to get, but it's still a gift. All right, a few comments about feedback methods. We're on the home stretch. I know you all are aware that there have been many feedback rubrics that have been described. The sandwich, the ask, tell, ask, the adapt method, or the reflective feedback conversation are examples. No one method works best every time for everyone. The more involved methods might work well for some people, but not be as approachable for others. For example, I can understand conceptually that the reflective feedback conversation checks all the boxes, but it doesn't work well for me in my current work life and with my current skills. So what's the solution? In the course of preparing for this talk, I came across the term bespoke. Like, I'd only heard bespoke in terms of clothing before. But it connotes that individualized feedback tailored to the situation and the specific giver and receiver are going to be the best approach. So you don't necessarily need to stick to one particular rubric. You can choose one that works best for you, one of the many available, or a hybrid that works out to meet your needs. So in other words, feedback tailored to the comfort and characteristics of the giver and receiver may provide the best fit. In that regard, there are really only 3 minimum key components to keep in mind for constructive feedback. And beyond that, you can add on and embellish. And I've listed the 3 here. It starts with an observation. I've noticed that. The next thing is why. Why change is important. So something like, when you do X, it can lead to Y. So this could be a patient care consequence or how you could be perceived, something like that. And the last part is suggestion for change. That's it. That was kind of wow for me. That's it. That's the minimum that, that can get you there. Pretty simple and straightforward. All right, so I have a couple of examples, and this does not apply to any current resident, so let me just say that up front. So for the resident with rambling presentations, I've noticed your presentations have a lot of detail, and sometimes key information gets buried. When listening, I can sometimes get lost and have trouble focusing on the important part of your story. It might work better if you could give me a headline or a topic sentence at the top of the presentation so I can know what to focus on. You might also trim out some of the negatives like no fever, chills, night sweats to help make your presentations more polished and succinct. And this one is for a resident with an anxious bedside manner. I've noticed that in your patient interactions, you sometimes seem anxious and give the appearance of being hesitant or uncertain. Patients can pick up on that and feel anxious themselves. Think about what you want to see in your own position, more of a calm, we've got this type of demeanor. What you project influences the character of the care you provide. Can you picture yourself learning to project more calm confidence and control in your encounters, even if you still might feel anxious internally? Not exactly fake it until you make it, but something similar to that. And then we might go on a little further. So these two examples, not perfect feedback, not hit it out of the park feedback, but the requirements are simple and approachable enough that even those of us who are reluctant and can't remember all the latest details can still do a good job. Just 3 things: observation, why important, suggestion for change. And you can add on if you want. So it can be nice to add on some component of ask. How do you think you're doing? How did that go for you? It can be nice to add on some component of a more collaborative problem solving. Of course, that's if you're verbal live feedback. Let's try to figure out some options. What are your thoughts about how you might address this? All right. Moving on to the how I do it section, I'd like to share some of my guiding principles with the caveat that I am still a work in progress. Definitely things that I am still trying to do better. I try to be good about providing in-the-moment feedback when possible. For example, feedback on note documentation or bedside manner. I've not been good about remembering to signpost that, to say, is this a good time for some feedback? I know that that would be helpful so that receivers understand this is a feedback moment, but I don't always remember to do that. I almost always meet with residents for formal summative feedback towards the end of the rotation, but sometimes I miss, even though I have good intentions. I recognize that a regular meeting earlier in the rotation could be helpful, such as a mid-rotation meeting, as Dr. Huang and I were talking about earlier. But I haven't been able to make it a matter of routine. When residents request it, we can meet earlier, such as beginning of the rotation to set goals or mid-rotation to allow for adjustments in the second half. I let the patients know that the verbal feedback I provide them will be mirrored in their written feedback. So no secrets. I have the goal of honesty and transparency with no surprises. I am horrible at the impromptu feedback session. If someone comes up to me in the hall and says, can I have some feedback? I can't do it. I need more time to figure it out and to prepare myself. So I'll say, yes, we can, but how does 2 days from now sound? I try to systematically consider the residents' particular strengths as well as any performance gaps. Where there are gaps, I consider what the possible fixes might be. Because remember that feedback should always be actionable. It's not helpful to say poor judgment. You need to think about, or I need to think about, what are the helpful and supportive things that I can provide to help the learner make some improvements. Okay, when the feedback is developmental, I definitely need to think about how best to frame it in a way that is respectful and supportive and attentive to the individual self-esteem. Sometimes I ask others. So maybe there's something about this resident's performance that I can't quite put my finger on it. What is it exactly, and how would it be addressed? I'll ask my colleagues, and I found that to be super helpful because somebody else's lens can really add to your own. I use a template to keep myself organized. So this is my meeting template that I set up. It starts with questions about self-assessment and rotation assessment, but ahead of time, I'll do the rest of it. I will fill in some bullet points for myself, having to do with their clinic skills, their OR skills, inpatient, interpersonal communication. And then under the general category, that's kind of anything else. So it can be things like style and funded knowledge or decision-making. For more senior residents, it can be comments about teaching or there are some leadership topics. Each of these items usually ends up with a few bullet points, and some of those are the shout out positives, and some of them are formative items. I prefer to meet in person for summative feedback, for the give and take of it, and to allow for clarifications. If for some reason an in-person meeting was not possible, I will still give them my written notes on that same template. And I'll give it to them directly via an email. Like, it's not a secret, this is me reaching out to you, and here's the information. We've had a couple of sessions this year on FaceTime because we just ran out of time during the rotation. I sometimes may call out my intention, and I think if I'm feeling a little more personally anxious about what I'm going to say, I will say that this is given to you and for you because I care about your success. Keep in mind, it's my perspective. I'm giving it to you to consider. And then we have the meeting usually directed by that template. And at the end of the meeting, I will take my written notes that I've been glancing at, and I will hand it to the resident. This is for you. That way, they have a record. You know, in case there's something they missed or they didn't remember exactly what I said, they have it. They can review it at their leisure. I tell them, please feel free to reach out if you have any questions or comments. If you want to meet further in the future, absolutely. I will support you in any way I can. Okay, that was a lot. Couple of concluding remarks. I hope I've been able to convince you in the audience and in the bigger audience in the virtual world that feedback is worth the discomfort. It is challenging, but it is a critical aspect of individual and collective growth and to the goal of excellent patient care and safety now and future. The barriers are surmountable. Retaliation is overestimated. In the moment feedback need not be time consuming. And there are many motivations to overcome personal reluctance. Find one or two that speak to you. Feedback skills can be developed. Please don't get stuck in silent disappointment. Do maintain a behavioral approach. Do focus on specific, actionable competencies. Be sure to bring forward your best intentions. Don't worry too much about falling short of a specific feedback rubric, but do work on your own bespoke feedback approach. Yes, you can. Adopt a growth mindset on your own behalf. You need not provide perfect feedback, but you can build your skill and comfort level. I'd like to encourage everyone to step up, lean in, and try, because feedback is important, and because, yes, you can. That's all I have. I'd like to thank Dr. Stankovic for inviting me to speak. And a quick shout out, I'd like to acknowledge the residents who have borne with me as I have worked on my skills, who have received my feedback with grace, and from whom I have learned so much. That's it.
Well, Lori, that's terrific. Things have changed with resident training since you and I were residents. When we were called into the chief's office, it was always bad. We never got positive reinforcement, which we desperately needed when we were so insecure. It's been a huge change listening to your talk and showing what resident education has evolved and progressed. Well done.
Thank you, George.
Lori, that was outstanding.
Jason, are there any questions from the chat? I can't access.
Can you hear me?
Yeah.
Lori? Lori, I thought that you did an outstanding job, and there was a lot of useful information in there for us to be better teachers. And I think as parents, it also applies significantly to the way you give feedback to your kids. So thanks for sharing that with us.
Thank you. And I will say that the converse is true. I think some of my approach to teaching has been benefited by having been a parent and having read through parenting books about, how to help your child along their way. So good point.
Hey, Lori, Kwong here. That was really terrific. I apologize. I missed the first 15 minutes of the talk because I was still operating. But there's so much information that's valuable in this. I'll have to go back and rewatch, and this will be really terrific ground rounds for our archives to give to our clinical instructors as they come through, and new faculty as well. So I really enjoyed what I heard today.
Thanks so much, Ron. I appreciate it.
I have a question, Lori.
Yeah.
I really like the way that you feedback.
Yeah.
As you're delivering it, because you already kind of know what you want to say, if you ever find that you need to change course in how you deliver feedback based on what you're reading, like in person,
Yeah.
you're reading from the person, like what are the signs that if your feedback isn't sitting where you want it to sit
Yeah.
with the person that you're giving the feedback?
So I'm not reading it exactly. It's some bullet points to remind me, the things that I want to remember to say. I am generally trying to follow the rule of observations without the assumptions or without the reflection on the person. I think when we are in person, then if it's being received the wrong way, it may be because I'm not explaining myself clearly. Absolutely, I want the resident to tell me how they see it. That maybe I've seen it the wrong way, because I don't feel like I have to be right. I mean, I know I am not right. I've developed some perceptions. Show me where I'm wrong. And I don't mean that in a mean way. I mean it in a, let's have effective communication one to the other.
I think we're very lucky to have very earnest residents. Really,
Mhm.
In general, maybe not even outside the training aspect, like saying feedback, you need it for a lot of other life skills too.
Yes.
I think sometimes it's even outside the system.
I mean, I agree, and I brought that up to residents who, when they're graduating chiefs, and we know they're not going into academics. I can think of a few that I've definitely counseled about. You need to get rid of the silent disappointment. You're going to be a leader of a team in the OR. You're going to be a leader of a team in the clinic. You're going to have leadership roles, and silent disappointment just does not cut it. Again, trying to explain the why and make it relevant. It's eating you up, and it's not achieving the goal of everyone's forward progress.
Terrific.
Thank you. Yes. Press it again. Press it, you see it green. There's it's.
So I talk to a lot of junior faculty,
Mhm.
and because they get teaching evaluations back, and it goes into their consideration for promotion and things like
Yeah.
that, a lot of them fear giving bad feedback
Mhm.
for retaliation. Do you have any advice for junior?
Yeah. So earlier in the talk, I shared a couple of papers to that topic that the fear is real, but it's the reality is not does not support that about retaliation. I think part of it is really the intent you bring. You know, if you are saying mean and unkind things, I mean, you're going to get what you sow, or maybe. But if you are saying things that really are meant with the intent to be helpful, I think that the risk is really quite low. I also strongly feel that if you're going to write it, you should be saying it, that you should be owning it. If you can't say it to the learner, you shouldn't be behind the back, you know, kind of putting it in a written format, I think. And if you can say it to the learner, and then we can come to some agreement about what this issue is, then if it's in the written evaluation, you know, we've already come to some agreement about it, that you're going to work on X and Y, and that maybe I've seen some improvement since we talked. And so I think a lot of it comes down to intent and also honesty and transparency. You can't backstab. Yeah.
I think the hour is at hand. Thank you so
All right.
much, Lori.
All right. You're welcome. Thanks for having me.